to Surrogate Social. I'm Monica Buehler with Cell Conceptions, and I have a very special guest with me today. This is Allyn, nurse practitioner, who does our surrogate medical records review. So she has a very special outlook on everything. So I would like her to share her perspective on how important it is to review records and share a little bit more about her story too. So Allyn, please just introduce yourself and kind of give us a little bit of your backstory also, what led you into nursing and what led you into medical records review special, you know?
I know I know everyone's dying to put that as their professional goal in life, to be a record reviewer. But I've always loved medicine. I grew up just like watching, I was like a kid that watched like, I don't know, people today don't have like TLC, the Learning Channel maybe, but they used to like have surgeries on there. And I used to sit and like eat dinner and watch operations on TV. I was that weird kid. And so I always loved medicine. And so I decided to go into nursing, and I started out on an OBGYN floor. I always loved OBGYN. So that was 2005. So 20 years ago, I was a little baby nurse, and I worked in the NICU. Worked postpartum. I took care of post-op hysterectomy patients. Did a lot in that realm. After 2 years, I was like, you know what? I don't really want to do night shift anymore. I'm not really a night owl. And so I was looking anywhere in the area for any kind of OBGYN job. And the only job in the area that was hiring at the time that had a day job was actually the infertility department over at the local university. So I applied and got hired. So that's really, people think when they hear my story that I got into infertility for other reasons. And I'm like, it really was just because I wanted off the night shift. That was my initial reason for getting into infertility. But I ended up falling in love with it. And especially the university setting, it's such a place where they let me go into surgery with them. And they're like, hey, go to this resident lecture. We have fellows over here doing this. So I got to go into all kind of medical school things, which was pretty cool when you're learning REI, because it's such a little, and it's a whole new world. That really fostered my learning. And so it made me want to go back to graduate school. So I went back to graduate school. In the middle of that, I left Mississippi and moved to California. So I wasn't from Mississippi, lived in there for my first 25 years of life, moved to California, finished my nurse practitioner at San Diego State University. And so I am a women's health nurse practitioner. Kind of toward the end of my job, though, before I moved, I started realizing through my just job training that something probably wasn't quite right with me. And I realized that I had PCOS and I wasn't ovulating. And so I was kind of doing my own sort of fertility workup. So this kind of fueled my interest in the field. So when people hear my fertility story, they think that's why I started working in it. I'm like, no, I was just tired and wanted to work during the day. But then it was really a blessing because I was like, oh, I learned all this stuff that I was going to go through. So during this time, and this move to California, and during my graduate school, I was going through fertility testing for myself. Turns out I went through surgery. I also have endometriosis. And so I ended up going through just kind of total. I ended up going through 13 years of infertility. I went through about 10 medication cycles, 5 IUIs, 6 IVF egg retrievals, and 7 embryo transfers to have my 2 kids. So I also understand from the patient side, understand like what our gestational carriers go through, as far as I've been through a lot of transfers. I know I can tell you what a progesterone shot feels like for real. But I think that just kind of kept me in the field for so long because I just fell in love with it because I was also a patient and I just know what it feels like to go through it. And it's a very isolating diagnosis and journey. Yeah. And so that led me, after nurse practitioner in 2012, I never really left the field of REI. I just kind of stayed. And then, surrogacy, has kind of been an evolving field. I started in REI in 2007. So there wasn't a whole lot. There was surrogacy, but it's really grown since then. Our field has really exploded since then. And so it's crazy for me to say I've been in IVF almost 20 years, and there's so many changes that have happened. And so one of them that I really saw firsthand was working in a large IVF in California. I spent 14 years practicing in California. When I lived there. And so I practiced at a really large IVF clinic for many years. And we had a lot of third-party reproduction. And as the nurse practitioner, I got to really be a heart. And so I did a lot of the medical screenings for egg donors and surrogates. So, at first it was just kind of like they came in and you screened them and maybe they had some medical records with them and then you would screen them and then you would kind of like go in and talk to them and you would realize that they were a terrible candidate. And you were like, why are we wasting our time and money? Like, this is not a good candidate for this intended parent. And these screenings are not cheap. When they make it into the office, I mean, these are not cheap. And so then it kind of evolved into, hey, we should at least look at their medical records and kind of do a little screening to see, like, should we even spend the money to bring them to the office? So that's kind of where the medical record review came in. And as a nurse practitioner at a busy clinic, I can tell you, I used to do it as part of my job at the clinic. You'd have to review these records, but it would get so backlogged because you're dealing with all the other patients in the clinic and the patients needing callbacks and everything. That email sitting in your box about a patient you have in a couple of weeks is not really top of your mind. So it's really nice that now, I created a company a few years ago to help out clinics to say, hey, I will review your records for you because I know that you're busy taking care of hands-on patients there. And I'm happy to do that because I did decide to move to Tennessee about 2.5 years ago. And the third-party reproduction is so big in Eastern Tennessee. But through technology, I'm still able to be a part of that world and help and just help out my fellow colleagues that are doing the hard work in the trenches and they're doing the medical screening. So I'm really privileged and thankful that I can be a part of the world through that.
Yeah, so it's super awesome from the agency side too. So then it allows us, like with your consulting, to then allow us to give us the pre-screen to the pre-screen, for our candidates. So then we can present your pre-screen to the clinic, so then you supply us with a letter and, you have a very systematic way of going through it. So then it gives them, basically your pre-approval to the pre-approval, so it's a very nice system that you supplied. So it's really great. It's very beneficial to us from the agency side because obviously we're not providers, in-house. So yes, we go through the records ourselves, but then it gives us that extra level of our pre-screen, because we basically say our pre-screening nurse is going to take a look at it, and so it gives us that reassurance too that, yes, I look through them and I have an OBGYN background, but I'm not a nurse practitioner, and so it gives me that kind of security that we've looked through them properly also, and that you're double checking us too. So it's great all around. Yeah.
Happy to be
Perfect.
able to be a part.
And then, we love it. It's been so great for us. I wish that it would have been around, like you said, years ago, we used to literally just send everybody with limited to sometimes no records, I'm talking 20 years ago. I don't even remember really collecting much records back in the day, to say the least, it was very minimal that everyone just kind of went to the doctor and that was the screening, and so it was like the Wild West 20 years ago, a little bit. So, so talk to me a little bit about why pre-screening the records is so important, and kind of eliminating some of those. Well, you talked about just saving costs and stuff like that, but just even from the agency standpoint, for us, eliminating some of those candidates from the beginning, as hard as it is, I would love to accept everybody. I hate telling girls no, or unfortunately, so, talk to me a little bit about why it's so important to limit the risks, even from a medical standpoint, why certain girls can't move forward as a surrogate, or, why it would be risky for an intended parent to select a surrogate with certain medical conditions or certain things in their records that, make you say there's reasons that this girl shouldn't be a surrogate, or there's additional risk selecting her as your surrogate.
Sure. I'm sorry. Well, I think, first of all, when you look at a woman coming in wanting to be a surrogate, first of all, you want to tell all of them yes, because what a giving heart that they have, that they want to do this for somebody. So I get that. And I, from that side of things, I'm like, man, I wish I could, give approval to everybody. I think being an IVF mom myself, I did not use a gestational carrier, but I think being an IVF mama myself, I just am thinking, okay, I am screening these medical records as if this is a candidate that I would be wanting to carry my own child. And so I also want these intended parents to have the best outcomes for their child. And I also know, these gestational carriers, they have the best intentions. But I think, if there were a poor medical outcome, that would also be terrible for the gestational carrier to go through that if there was a tragic thing that happened, and they weren't properly screened and we kind of knew there were risk factors, and then they don't want to have that on them either. So, I think it's really fair for both sides to say, okay, here's the risks and benefits to this. I mean, we never know how someone's going to do in pregnancy. Every pregnancy can be different, but there are risk factors that carry over throughout pregnancies. You do have to have at least one pregnancy because we don't know how you're being pregnant. And then, there's certain risk factors that are more medical based that you really can't control. Like if you have preeclampsia, that's just something that we don't really know. I mean, it's an interesting thing. It's still being studied. We don't know why some people get it and some people don't, but we know that there is an increased risk of getting it in a future pregnancy. There's an increased risk at getting it earlier sometimes. So even if someone's like, well, I made it to 37 weeks, it's like, yeah, but sometimes there's an increased risk of you getting it earlier. So what if you get it at 32 weeks and now you've got a baby that's in NICU, and that sort of things. We look at that. And then also IVF holds its own special risk. So IVF pregnancies also carry a risk of increased risk for preeclampsia and IUGR, which are placental issues. That's another reason when we see placental issues, we're like, okay, they had a baby with a natural conception with placental issues. IVF pregnancies increase the risk of that. So, okay, we're looking at really having, double whammy here on a placental issue. That also could cause an earlier delivery. This baby's not very big. The placenta is not feeding this baby. It'd be better for us to put this baby in the NICU and feed it. And, while we have wonderful, wonderful NICU care, our goal is to select candidates that are going to have live births at term, because that is the healthiest way to have a baby. That's just, we're trying to eliminate risk where for mom and baby. And, that's another thing for the gestational carrier, if there's some risk to them, sometimes, we don't want you to have had more than 3 C-sections or 5 vaginal deliveries. So you can be approved for a 4th C-section. You can be approved for a 6th vaginal delivery. There are cases where we've made exceptions and people have had them. But again, it almost becomes more dangerous for the carrier because when we call them grand mole tips, or I've had lots of babies, there's a lot of risk to the and so, as generous as you want to be to carry this baby, like we worry about your health too, because, you've had all these babies, like you have some kids at home too. Like we want you to be around for their future as well. So there's just so many things that we think about, and it's not and then, okay, so I kind of touched on the medical. The other thing I look at is just social issues. And when I'm talking about all these issues, there is there's a document that I've even sent people before. It's through ASRM, which is American Society for Reproductive Medicine, and which is kind of the guiding society for all that we do in IVF in our country. It has guidelines for clinics selecting gestational carriers. It's guidelines. It's not written in stone.
That's what we use too as our right. That's what we use as our governing guideline as well.
Right. And I think it's tricky because it's guidelines, but it's based, even though it's guidelines, it's based on research. And so, some clinics are a little more loose with it. Some intended parents would be like, I don't care. The research says that. I'm okay with that. Or some intended parents are like, absolutely not. So, there's it's a little bit of gray, but I tend to lean a little bit more toward, I want the safest possible thing. I want as close to in those guidelines as possible. And so, things like marijuana. Okay, like marijuana is legal in California. But, if I'm looking at a record and someone had a baby 10 years ago and they had marijuana use in their first trimester, they didn't know they were pregnant. They didn't use marijuana at all the rest of the pregnancy. They haven't used it since. They have no drug use in pregnancy. I'm probably not going to be concerned about that patient's drug use in pregnancy. You have someone that has 3 pregnancies and drug use documented in each pregnancy, I am going to be
every time.
Right. So it's not like a one size fits all. there's a pattern. So there's different things like that where it's like, oh, if I have, oh my gosh, I was 18 years old and I didn't even know I was pregnant and, all that. And, you're a 28-year-old now and a mom of 3 and you don't like, that's not going to ding you. But, it's more like the patterns and things like that, because we want gestational carriers that make healthy, good decisions, because we don't want you being tempted or having addictions that are going to come up during a surrogacy pregnancy.
Yeah. So then back to just, because I always am concerned too, like when, like we will always want to say yes to everybody, of course, right? But no, it goes back to a lot of, I never want to ask a surrogate to put themselves at risk, right? When they say, well, I had preeclampsia at 37 weeks and I was fine, but then my thought is always, or, my comment back to the surrogate is I never want to ask you to put yourself at risk. Like, you need to be able to be at home for your babies and your children. And, I would never ask you to put yourself at risk for an intended parent, to give this selfless act for someone else. Right. And so it comes back to that as well. And like you mentioned, with each pregnancy, it's very different. Just because one pregnancy was this way or even completely uncomplicated, the next pregnancy could be completely complicated. We just can't predict. So we assume that a pregnancy is going to be that again, but and so it kind of comes down to that as well. Can you go back to also when you were explaining the intergrowth restriction, can you just explain a little bit in case someone doesn't know what that is, just a little bit of what that is and, kind of how that can also go from pregnancy to pregnancy also, and just a little bit about stature, and what that exactly is in a pregnancy?
Yeah. So IUGR is a term for intrauterine growth restriction. And all that means is how big is the baby. But a lot of times we say it's from placental insufficiency. The placenta is what's attached to the uterine wall and has the little umbilical cord coming out and attached to the baby. It essentially feeds the baby in the pregnancy. Most pregnancies, normal placenta, baby's fine, they grow, they're a normal size, all that. Well, sometimes they start to notice, oh, mom's belly at her visit is not measuring as big as we expect it to. They do that little measurement, or, we do a little fluid check and something's just not quite right. They do a growth ultrasound and they say, oh, baby's measuring 2 weeks behind. Okay, we need to do some serial growth ultrasounds. And is it all the full baby? Is it just the head? Is it just something else? And they're going to start looking into it. And then they sometimes will do a placental flow and they'll look at blood flow. Sometimes they will actually be able to tell by ultrasound the placenta is actually not being able to give the baby enough food. And when that becomes an issue, it becomes a high risk pregnancy. You're going to have just very frequent ultrasounds where they're going to look, because they're going to say, okay, at some point is the baby's growth just stagnant? If they're just staying the same size, then we need to take them out and put them in the NICU where we're actually able to feed them. And generally, this is a little bit of a NICU case. These babies are usually born smaller, as you would imagine. We call that SGA, or small for gestational age. Then we have LGA, large for gestational age, right? So these are usually things that are picked up during pregnancy, and these are things that are monitored. If you have a small for gestational age baby, that does not mean that you had placental issues. I have women who are like 4'11", they're little bitty women, and every single one of their babies are SGA. I've taken care of them in the hospital, and that's just their genetics. They're small people.
Yeah.
There's nothing wrong with their placentas. Just like there's some very large, tall people who are like, the dad, mom will both be like, mom will be like, well, I was 9 pounds when I was born. The dad's like, well, I was 11 pounds when I was born. I'm like, well, you guys have no chance of having a normal sized child, probably. And they all have big babies. So sometimes genetics play a role, but this is more founded in, there's actual things throughout the pregnancy that we're seeing and things like that. And so a lot of it, we don't know why. We don't really know why placentas don't develop like they should. But for whatever reason, it is a little bit of an increased risk with IVF pregnancies. And they do think it's a little bit increased risk in frozen embryo transfers for a reason. And that's what we typically always do. And so we don't know why. We just know there is a correlation there. And so if you tend to have those issues anyway, we'd be a little hesitant, right? I mean, we'd be like, you already have these issues. And, so it kind of depends on the situation. If you were kind of monitored, I mean, I have a lot of records where they think maybe there's a growth issue going on and they kind of monitor, and then baby was a little bit behind, but then they catch up, baby's born at 7 pounds, everything's fine. I'm not worried about that. It just might have been a baby was the measurement was done wrong, or maybe baby was just needed to have a growth spurt. I'm not worried about that. It's just if it's, you have a legit, diagnosis or something.
Right. And then there is some discrepancy in ultrasound imaging too, right? Like where you, like you said, it could just catch up with the next scan, right?
Absolutely. Yeah. This is more like, hey, it's gotten so bad that we're doing like placental flow tests and we're looking at, blood flow and, how much of the placenta, like it gets pretty detailed. When it's a true IUGR growth restriction case, like there's pretty detailed stuff in there. If it's just kind of like growth ultrasounds, like I had to have them with my son because I had a marginal cord insertion. He was born at 8 pounds. I mean, so I had growth ultrasounds for him. They were all normal, but
Right.
they just do that because he could have a growth problem because of my cord insertion. Like if somebody had that in their record, I wouldn't be concerned, especially if they had an 8-pound baby, like I'd be like, oh, they just do it as a precaution.
Right.
So nothing like that would be like, oh, they can't be a
Correct.
carrier. Yeah.
Right. Yeah. Yeah. Cause I always check like birth weight. Like if there was like extra scans, and I always kind of check birth weight too. Like there's little, like little tags that I look at and be like, okay, well, how much did the baby weigh? Or like how many weeks? Like I always kind of double check certain things, to look back at.
Yeah. And it's interesting.
So
too,
let's
when
talk
you look
about
at-
gestational diabetes. This is always a big one.
Yes. 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 Gestational
So,
diabetes is,
yeah.
yeah,
Yeah.
it's a hard one.
Yeah. So, yep. So, obviously if it's medication controlled, that's a hard denial, and so, what's the difference between, when surrogates apply, just so they can understand, especially, like if a gestational carrier is watching this, like, so they can understand the difference, what's the difference if it's diet controlled to if it was medication controlled? Why can somebody be a surrogate if it was just diet controlled rather than if they had gestational diabetes on medication? What's the difference between being able to move forward and not being able to move forward from a medical standpoint?
Okay. So gestational diabetes just means you develop diabetes while you're pregnant, and the risk is really to the baby. I mean, there are risks to mom later in life. If you have gestational diabetes, you are at risk for developing regular diabetes, as in yourself later, but there's not really, everything has to do with risk to the baby. We worry about the baby getting too big. There are risks for actually fetal death. Intrauterine fetal death is a little bit of increased risk with uncontrolled gestational diabetes, but also delivery. We always want the head to be the biggest presenting part on a baby, because if you think about it, if they're having a vaginal delivery and the head comes out and the abdomen is bigger than the head, the baby could actually get stuck. So you think about the head has to be the biggest presenting part, so we know the rest of the baby's coming out. So that's the biggest issue. And that's why we do a lot of growth ultrasounds on gestational diabetic patients to make sure they're okay for a vaginal delivery. That's the biggest thing. But yeah, there are those other, like all the way up to intrauterine fetal death. So there are other risks to the baby. Of course, baby also with uncontrolled sugars in mom, they're going to come out and probably have uncontrolled sugars. It's crazy to see these 9-pound babies in the NICU sometimes, but it's because they're used to having these high sugars, extra high sugars from mom, and now they're coming out. So now they're bottoming out. Then you have a NICU admission for a baby. So there's just a lot of things that have to do with it. As far as mom's control, it really is, when you're diet controlled, it's a mild case. When you can diet control it, it's really mild. It's something that you're able to just say, hey, I'm going to watch. I'm going to not eat, a lot of, white carbs. I'm going to stay away from the cakes and the breads and the things. And I'm really going to eat a good, healthy diet. I'm going to eat my, my green vegetables and my proteins. And I'm going to really tighten up, and that's a mild case, right? Because you're able to actually control it with diet. If you're not able to control it with diet, it's not a mild case. So that's kind of, when you look at, mild versus severe. I will say there's a little bit of a caveat for me on, so medication controlled diabetes in pregnancy. I have okayed some patients who have just been on metformin before. It just depends on the case, but insulin, I do not. Insulin's a hard no for me, because insulin is like even more beyond metformin. Metformin is an oral medication that you can take. It's pregnancy safe, but is a diabetic medication. But insulin is like very serious. That's like you're checking your blood sugar like 4 to 6 times a day. And it's like a very high risk pregnancy. Insulin is just, it's not something we joke around with. But, like for instance, a case that I would say I would approve for metformin. Mom has had 3 babies. She wants to be a gestational carrier. She had gestational diabetes in her first pregnancy on metformin, was in good control, had a normal sized baby. In her next 2 pregnancies, she did not have gestational diabetes. I'd be like, all right. I mean, she had it, metformin. Her next 2, she didn't have it, and she did well. So, like, that would be a case where I'd be like, okay, I'm okay with that, that kind of thing. So it just kind of depends on the case. Kind of same with preeclampsia is kind of the same as gestational diabetes. It really depends on the severity. HELP syndrome is a very severe form of PIH. So HELP syndrome is going to be like your insulin diabetics, right? Like it's the very severe. So, if someone has HELP syndrome, I'm going to be like, no, we're not going to try this again. And so it really is kind of on there's a continuum there. And also because there's women who have preeclampsia or they have elevated blood pressures at the end of pregnancy and they're watching them and maybe they have a little protein in the urine, but they go on and deliver. Maybe they're 38 weeks, they deliver, they're fine. Their pressures come down right away. They're never on meds for it. I'm like, okay, probably should put them on baby aspirin to start the next pregnancy because that really does help prevent elevated blood pressure. That patient was never on meds. Then you have the patients who maybe they had to go on some labetalol at the end of pregnancy, a little oral medication, or maybe afterwards, but they've done okay. You have the patient on magnesium, which is an IV medication that's super serious for like really bad preeclampsia, and you're on magnesium for 3 days in the hospital. Like, again, like that's very severe. So it kind of depends on, that's why you read the records, right? Just looking at a diagnosis of preeclampsia or looking at a diagnosis of gestational diabetes doesn't tell me enough.
Right. Yeah. So typically that's how I look at preeclampsia too. Like if it was in the first pregnancy and then like you said, they've had 2 pregnancies post and no issues with blood pressure, I feel like, and you can correct me if I'm wrong, then I feel like it kind of like erases the first one, and then we kind of are fresh, and so then we can look at those other 2 pregnancies as kind of cleared it. And as long as we can get OB clearance, and then we can move forward. And so would you view it that same way too?
Yes, exactly. I think that, anytime that you have the same way with preterm deliveries, like I had one recently where she had a baby at like 36 weeks. And if that had been her only pregnancy, I'd have been like, you haven't carried a baby to term. But then she had 2 more pregnancies where she had term delivery. So I'm like, okay, she had a preterm for whatever reason her body decided to have an early baby, but she's proven these next 2 that she's gone to term. So I'm okay with
Right. Right. Yeah. Okay. Yeah. So that's a good way to look at it too. So yeah, I always feel like if the last even pregnancy or even maybe 2 were close to perfect, then, it's especially like if it was a teen pregnancy, I think a lot of times they have like at that 38, 39 week, their blood pressure is high. Like sometimes I associate it, again, correct me if I'm wrong, like, that they're young, they're scared, their blood pressure spikes at delivery, but there's no magnesium used. And then, the next 2 are normal, things like that.
Yeah, elevated high blood pressure in pregnancy.
So, and then that obviously, like, so let's touch, yeah, for sure. Especially like at that, like when they're delivering, like, especially, you see it a lot, like, the day they go into labor, if you look at, like you're saying, if you're looking at the records, sometimes it's like quite literally the day of labor, and then you look at it, they're at the OB's office, they have a high reading, and then that next day or that night they're in labor and delivery. Sometimes you can quite literally see it in the records, right?
Right,
Yeah.
exactly.
So let's go back to preterm labor and why that can be a disqualifier. So, like if it's the last pregnancy or their only pregnancy, so describe what is deemed preterm labor, what the exact week is, what we classify as preterm labor, down to the week and the day, because it's kind of, everyone classifies it a little bit different, what that looks like, what is like truly preterm labor, and, kind of describe what that looks like and why that's a disqualifier.
Yeah. So again, we want babies to go to term to avoid NICU. Babies at term just have less health problems. There can be health problems with the baby the earlier they're delivered. So we're trying to get the healthiest babies. And so as a former NICU nurse, I mean, I'm a real big believer in this. So I would say, 38 weeks and 0 days is term, up to 40 weeks and 0 days.
Yep.
And after that's term, obviously. So, so if you're 37 weeks and 6 days, or 37 and 0 to 37 and 6, we consider that late preterm. So that's like that kind of middle area, like you're late preterm, but like probably gonna, And it kind of depends. Boys are worse than girls about going to NICU sometimes. So I used to say I would get the Caucasian boys are worse. So I'd say I'd get the wimpy white boys in there. So if I had a 37-year-old boy, like Caucasian male coming in, I'm like, he's probably going to the NICU. I get like a 35-week female, and I'm like, she's probably good. So, I mean, honestly, you never know. And it depends on, yeah, you just don't know.
Yeah.
I mean, I remember sitting in a transition nursery for like my whole 12-hour shift watching this baby just try to be in well baby and try as a 37-weeker. And he finally just like wore himself out breathing to go to NICU. So, I mean, there's a reason. We're not just trying to be mean. I mean, it's just like sometimes, and you may have had a 37-weeker that came home with you and never had a problem. And so you're like, I don't know what's the big deal, but that's just not everyone's story. And so, anything 36 weeks and 6 days and before is preterm. Generally, I consider anything under 32 weeks to be a micro preemie, but they may say under 30 weeks is micro preemie. But really, I mean, as far as preterm labor goes, there's a lot of people where you look through their records and they think they're having contractions or something and they go to the hospital. Like a lot of times it's Braxton Hicks or they got dehydrated or something. Like I don't consider that preterm labor. It's more if they're like patient here for contractions and she was given terbutaline. That is an actual medication to stop contractions. So if you're given anything more than IV fluids, you're given medication for contractions, I'm going to consider that you had some treatment for preterm labor. Now, if you went in one time and well, I mean, if you've had like one, like I say, you went in one night, you thought you were having some contractions, they gave you some terbutaline, you never went back to the hospital, and you delivered at 40 weeks. I'm like, well, maybe she just had like a little, it was just, I don't know, she got dehydrated or something happened. But a lot of times these patients, I'm a little suspicious of because it's like they went in at 23 weeks, they were back at 26 weeks, they're back at 29 weeks, and then they're back at 32 weeks, and then, oh, but I delivered at 36 and 6, and it's like, yeah, but you were like, really like pushing it and always having these preterm. And, you think about your intended parents. How awful does it have to be an intended parent to get this call like every 2 weeks thinking, my baby could be born early. My baby could be born. She's back in the hospital. She's back in the hospital. Like, that's terrible thinking, oh, I might have a 25-weeker. I might have a 28-weeker. I mean, that's not really fair. And so if it's like a consistent thing or, or all your babies have been, like if you've never had a baby after 38 weeks, I'm going to be like, you've never carried to term, So that's just, we just can't guarantee that even though your babies may have come home with you or not had significant issues, we can't guarantee that someone else's.
Yeah. And I think it goes back to also like, considering the surrogates themselves, right? Like we're also not going to ask them to be in and out of the hospital or on significant bed rest, right? Like, yes, they say, oh, I was fine. I was in and out of the hospital. But then what if it becomes severe hospital bed rest? Like you're leaving your babies behind. And then what if you're in the hospital for 6 weeks or an inversion? All these things. Like I think sometimes they don't realize what they're really signing themselves up for severe bed rest, what that looks like. So yeah, it's a big ask and a big risk, to be on that severe of a bed rest.
Absolutely.
So, okay, let's talk about BMI and why that's such a big guideline, and kind of what risk factors that can involve.
I'm glad you brought this up because, again, it's like, hard to tell people no when, they're just a little heavier, my goodness, they've had 3 kids, they're busy moms, they're like, I don't have time to, try to lose weight for this. So I definitely understand from that aspect. I think, again, it comes from the perspective of, we want the best outcome for the intended parents as well. Really ASRM guidelines, we really want it more like 30 BMI. So 30 BMI is the most ideal, 30 or under. But there's kind of been this like, okay, well, we'll accept up to 32. So 32 was kind of like the give, like, okay, well, we really want 30 or below, but we'll give up to 32.
Yeah.
So that was kind of the give in there. There's a couple of reasons. The main kind of reason that ASRM did it surrounding surrogacy is there is a decrease in implantation rate with a BMI over that. So where it goes, that you want to have a baby with, but we're going to get you a surrogate and you're going to have a decreased chance of this baby implanting because of BMI.
Mm-hmm.
And, most people are going to say, well, I don't want to decrease my chances. I mean, even if they have perfect pregnancies, I understand that. But the research tells us that when we put an embryo in you, you're going to have a lower success rate than someone with a lower BMI. And that's just honestly what the paper tells us. And so we're going to go based off of research piece, right? We want our, to be as successful as we can. We're not 100% in our field. No one has 100% transfer rates for anyone. But we want to be as successful as we can. But I think on the other hand, you have to look at pregnancy too. So when we look at things like preeclampsia and gestational diabetes, the higher someone's weight is, it does put them at an increased risk for developing those pregnancy complications as well. So, on a health standpoint, like, okay, we want to they have the best chance of an ongoing to get pregnant and to stay pregnant, and also to decrease their chances of having pregnancy complications, which also increases as weight increases. So we want the best chance for the patient. And it's hard because I have a lot of friends that are over that BMI that would, that had wonderful pregnancies. But it's just, it's a little different when it's your baby versus, you're being entrusted to be the carrier for this embryo and this baby in this scenario.
Yeah, for sure. I think it comes down to minimizing the risks across the board, right? For the intended parent, for the surrogate, and so typically what we do is someone is over, we always say, like, look, we're in it to win it, like, work on it. We'll be here when you're ready. We never turn anybody fully away. We'll say, like, we'll be here in 6 months, we'll be here in a year. And I've had girls come back in quite literally a year, actually multiple surrogates who've done multiple surrogacies with me through the years, who have worked on it and been very successful, and so it's a hard, it's a hard turn away, but I never want to put anybody at risk themselves, right? Because I never want to say to, their family, like, well, they were helping a family, but now, they have issues beyond the surrogacy to their health, Yeah.
Exactly. And I will say a little plug here, just from being a nurse practitioner so long, I really do love GLP-1 therapy. And so, I would say if someone's out there that wants to be a gestational carrier, it is probably the quickest way to lose the weight. I mean, you do want to be off of it by the time that you start a pregnancy journey, but more and more research is coming out that it's lowering insulin and lowering the glucose. So you're getting good, you're getting prepped for that good, pregnancy that way. And it's lowering inflammation in the body and lots of good things too. So I work with patients a lot on GLP-1s too. So I think, that's a really good route if surrogates want to kind of, you might could hit that BMI in a couple of months versus a year. So just a little plug on that. I'm a big fan.
Oh, I love that you said that, because I think, correct me if I'm wrong, I think they just have to be off of it like 2 months before we start IVF meds, correct? Yeah, that's about the standard. Yeah. Yeah, I love that you said that.
And it probably takes that long to get people.
Yeah, I love that you said that, because I think that that's a really great option. And, yes, it's expensive, but I think it's getting a little bit more affordable, now and stuff like that. Like, even if they can't get their insurance to cover it and things like that, there's other options. So I love that you said that. That's great. Yeah. So kind of in closing, thank you so much. I think that this was super educational and, super helpful, and kind of gives insight to, the reason behind the, sometimes why we have to tell girls, like, not now, or maybe a hard no, or come back to us at another point, so, and thank you so much again for sharing, like, your personal IVF story too. I know that's very personal. So thank you for sharing that side too. So, to touch again a little bit more, what does it mean to you from, like, behind the scenes to be, kind of behind the scenes of getting everybody to the journey to parenthood, and what, share a little bit on that, and just how much it means to you to be a part of it on that family building side.
Yeah, well, I truly did enjoy working in a lot of third party reproduction when I'm still getting to be a part of the third
Yeah.
party reproduction world through this and helping build families. I just love I love helping build families. I actually started a nonprofit called Defiantly Hopeful, and we do an IVF grant. Once every year. We took off last year, but we have one coming this year. So opening up applications soon. So I started that just to help people build families, because I know how hard it is just to, it's so expensive and such a process.
Mm.
And even the surrogacy journey from the perspective of the surrogate, going through the process. I mean, it's not an easy process for them to go through. As it's a very long process, and it's just it's very intense process.
Yeah.
And so just to get to play a small part in helping, I know it's a huge journey, and third party, you have the surrogate and you have the intended parents, then you have that baby, and it's just the you guys really get to all part of that. It's really rewarding, and I've just always enjoyed every part of being in the infertility world and helping people have that, because I just think there's no greater legacy in life than helping people build their families.
Yeah, well, I appreciate it. You're a huge asset to us on, and starting that in the very beginning, to us. And we value your input and your knowledge, and it's a tremendous help to us. And we're very grateful that, we are able to partner with you, and we're very grateful that, you're a part of us and our team. And we're really great. It's so awesome. So thank you so much. And thank you so much for being a part of this today. And so tell us again your nonprofit, and we'll make sure to give it a plug. What was the name of the nonprofit?
Oh yeah, it's Defiantly Hopeful, and it's defiantlyhopeful.org. And I think October 1st, you can go to the website and the application will be live. It'll be a $15,000 grant toward IVF services.
Oh my gosh, that's so awesome. Okay, so we'll share all that information and make sure that we get that out there. That's amazing. That's super awesome. Well, thank you so much, Allyn. This was amazing, and I really appreciate you, and you're a huge asset to us, and we're so grateful for all the help that you give us on a daily basis. So thank you again.
No, it's my pleasure.
All right, thanks so much. Take care.
Bye.